So you want to get
I
back.
basically just said, I asked
The Monday
this,
after
and I asked what she said.
for past this.
Okay.
I'm probably just gonna put it.
What's the title of your assignment?
Nurse leader interview.
Oh, that, yes. Yeah.
I'm sure.
Oh, no.
Yeah. I'm just gonna look at it. What's left? I said that she probably started that project. Yeah. You're gonna take case presentation.
Yeah, this is the thing.
Here's my case study. I have my case study. But I haven't put it in stuff.
I'm just trying to put it in words.
I just
Is
hope
that
I
for
can-
number?
Yeah. I just hope I can actually talk for long enough, because I want to figure it out.
That's between you and Troy.
Are you all ready for break?
15 to 21.
15 content, 5 questions.
What'd you ask me?
Are you all ready for break?
Yes.
Please, I'm excited.
Which one are you doing?
Yes.
You could cancel class,
Yeah,
just
I just did mine
record
yesterday,
lecture and
and I'm doing it
send
next
us
week.
on our way.
Let's just get through it. I've already had to finish recording the last lecture because I didn't get through it and we didn't have time to like do it without.
Oh, is he on the bright space?
Hmm?
Is he on the bright space?
For the others,
Be cared for during clinic.
not for you all.
Okay, last.
Last
your
lecture,
Like,
yeah,
we're gonna be-
like my last class. No, we're doing DKA in class because I feel like it's important.
Oh, yeah, I mean, I would think so.
I don't say everything's important, but I feel like this is important because you all will actually see this. All right, guys. So we're gonna go ahead and get started, and if we're joined by others, we can be joined, and if not, then that's okay too. Alrighty? So any prayer requests for the day, the week, travel mercies, anything else? Are you all going anywhere exciting?
I'm going on the break for change trip with Kim.
Nice!
So,
You're going to South America, yes?
no,
No.
DR.
Okay, okay. I understand. No, you're getting kicked out, Caleb. Anyone else going anywhere exciting?
My baby child shower this Saturday.
Oh, that's awesome. It's getting closer. You're almost there. What, May, mid-May?
I think they may take her on the night.
Are they? So you have 2 months. That's exciting. Aw. All right, guys. So let's pray, and then we'll get started. I have a few weird, different things to do today, so we'll try to keep it a little light. Okay? Father, thank you for this day. Thank you for letting us come together, arrive here safely, and be able to learn a little bit more about the endocrine system. I pray that you will be with these students as they go through spring break. I pray that you will bless their time with their friends and their family. And Father, if they travel anywhere, please keep them safe. And Father, keep us safe as we travel as well. In your name I pray. Amen. Yeah, we were going to go to Washington, D.C. for Theodore's 8th grade trip. And then they decided to declare war. So I was like, there's,
In Washington?
no, with Iran.
Wait.
There's the current Iranian war. Like a couple weeks ago.
Yeah,
Yeah.
Sorry.
So I was
Wait.
like, I
I know
really
the
don't
gas
want to
prices
go
are up
to
there.
DC while there's active fighting elsewhere in the world. That's just not something I really want to do. So we're going to Jamestown, Williamsburg, and
Oh,
Yorktown.
it's so pretty over there.
We are so
I've been
excited.
there.
Yes.
When I was a kid. I
Really?
remember a lot. We had a high school trip over there.
So we're finishing up our colonial tour. We did Boston last spring for the 250th anniversary, and now we're traveling to some of the other original colonies. Yeah. All right, guys. So DKA. What do we know about DKA?
It's not good.
It's not good. That's right. It's not good. It's a bad thing. Okay. So diabetic ketoacidosis is an acute, life-threatening emergency that occurs most commonly in our patients with type 1 diabetes, especially those with new diagnoses, those who have interruption in their therapy, or those who have just decided to stop taking their therapy, which actually happens more often than you would imagine. Why are you here? Well, I just stopped taking my insulin about 3 weeks ago. Oh, okay. And why did you do this? I just didn't want to do it anymore. Okay. Okay, that's up to you. So you want me to treat you, right? Yeah, let's get me treated. Okay, that sounds like a plan. So it's characterized by a few different things. Severe hyperglycemia, metabolic acidosis, and the accumulation of ketones in the blood and urine. Blood glucose levels are typically greater than 300, although they can rise significantly higher than that. And the onset of DKA is rapid. It usually develops within about 24 hours. The defining feature is an absolute to near absolute insulin deficiency, and without insulin, that person's glucose can't enter their cells, and it forces the body to break down fat and protein for energy, and that is the process that causes ketone bodies to form, leading to the acidosis and to really rapid clinical deterioration.
So it's just fat that's getting broken down?
Yeah, and that's how we get our ketones, it's from those fatty acids. DKA occurs most commonly in individuals with type 1 diabetes, but it can occur in people with type 2 in periods of really extreme stress, like severe illness, some kind of surgeries. The most common precipitating factor is insufficient insulin, which results from undiagnosed diabetes, untreated diabetes, or non-adherence to their insulin regimens. And missed doses of the insulin can also be a factor. Any condition that increases insulin demand can trigger DKA. Infection is a common cause, but physical and emotional stress can cause it, trauma, surgery, and acute illness. During stress, counter-regulatory hormones like cortisol, glucagon, and epinephrine increase, and these hormones stimulate hepatic glucose production and decrease insulin effectiveness. So what are we going to see in these patients? Early manifestations typically related to hyperglycemia are the elevated blood sugar and dehydration. These patients are going to come in and they're going to have polyuria due to osmotic diuresis, followed by polydipsia as the body attempts to compensate for fluid losses. They can also develop some polyphagia due to some cellular starvation. And as that insulin deficiency persists, the body enters a catabolic state where it's breaking down fat and protein for energy, leading to weight loss and accumulation of ketones in the blood. As the dehydration worsens, those patients can become weak, fatigue, they can develop headache, blurred vision, nausea, vomiting, a rapid weak pulse. Sometimes they present with some abdominal pain. Classic hallmark findings include a fruity, acetone-smelling breath caused by acetone exhalation, and they also have the Kussmaul's respirations, which are those deep, rapid respirations that occur as the body attempts to compensate for that metabolic acidosis by trying to quickly eliminate that CO2. Neurologic changes can develop as the dehydration and acidosis continue, and it can be confusion, altered mental status, decreased level of consciousness, and this can all progress to coma and sometimes even death. You know, I've never smelled the fruity smelling breath. Not that it hasn't happened, I literally can't smell it. I can't detect it. I've had nurses say, "Do you not smell it?" No. No, I can't smell it. So when we're looking at labs of DKA patients, we're looking to confirm the elevation of the blood sugar, but there are a few things that we're also looking at. So blood glucose levels are typically above 300, although sometimes we just say 200 is sufficient to meet the diagnostic criteria of DKA if this is accompanied by acidosis and ketosis. In DKA, ketones are present in both the blood and the urine due to that metabolism of fat, And this really is the defining diagnostic feature of DKA. Blood ketone testing is the preferred method. Arterial blood gas reveals metabolic acidosis, and there's usually a pH below 7.35 with a bicarb below 18. And we see that attempt of respiratory compensation with the Kussmaul's breathing. The anion gap is usually elevated due to an accumulation of ketones. We can see electrolyte abnormalities, and this is pretty common. Typically, we will see potassium levels that are normal at first because of that insulin deficiency, though the acidosis causes potassium to shift out of the cells. And even though the body's potassium is depleted, at first we're not really able to see it until we start replacing that insulin. After we start noting that that potassium is lower, we have to then initiate replacement of the potassium, because if we don't have adequate potassium, we're at risk for the cardiac rhythm abnormalities. Sodium levels can also be low due to fluid shifts and dilution, and BUN and creatinine levels are usually elevated because of the dehydration. So when we're treating DKA, we're really focused on reversing dehydration and correcting the insulin deficiency. We also want to resolve any kind of metabolic acidosis and restore electrolyte balance. But we always, like in sepsis, start with aggressive fluid resuscitation. So we're going to provide them some isotonic saline, which is the first priority. Initially, we provide a 1 liter bolus of normal saline, and after that fluid infusion is completed, then the provider is going to order labs to make sure that we are rehydrating, and we're also going to be monitoring those electrolytes very closely. So patients with DKA often require large volumes of IV fluids, sometimes up to 6 to 9 liters over 24 hours in order to make sure that we're rehydrating them appropriately. Patients also must have potassium managed through DKA treatment, and this is always addressed before insulin is started. So even if the initial potassium level looks normal or slightly elevated, the patient is usually potassium depleted due to osmotic diuresis and urinary losses. Insulin drives potassium back into the cells, and this can cause a sudden dangerous drop in the serum potassium. For this reason, insulin should never be started unless the potassium is 3.3. So in all DKA protocols, the potassium is what you're waiting on before the insulin infusion is started. Never ever start the insulin before you know what the potassium is.
You said
3.3.
What's the normal range?
3.5 to 5.3.
Yes.
So if it's any lower than 3.3, we don't want it.
If it's 3.3, it has to be at least 3.3.
Yeah, if it's any lower, we do not want to be giving, we need to up it first.
Yeah, we have to replace the potassium. Yeah,
So you said at least 3.3 or below?
at least.
Okay.
At least 3.3.
Because the insulin is going to shove it all back into the cells and you're going to have clean.
Yes, that is correct. Yes. When we do initiate insulin therapy, it usually begins with an IV bolus of regular insulin, and this is a weight-based bolus. And in order to calculate that, the bolus is going to be 1 unit per kilo, and then it's followed by a continuous insulin infusion at a rate of 1 unit per kilogram per hour. And at that point, we are trying to address the hyperglycemia that the patient is experiencing. This will also help reverse the ketosis that they are experiencing. But it's important to also be providing fluids with glucose in them at that time to make sure that we're not precipitating worsening effects of that patient. So let's talk briefly about calculating that
So
Insulin.
1 unit or 0.1 unit?
0.1. 0.1 units, not 1. If you give them 1 unit, you're in pill. Yeah, 1 unit per kilo. I mean, if they're 70 kilos, that'd be 70 units. Can you imagine? That'd be horrible. And this is why insulin is also usually double checked by the nurses, right? It's one of those critical drugs that you always have to have 2 sets of eyes on to sign off. Insulin, heparin, those medications have to have a double check. And most hospital facilities won't even let you scan the medication unless someone signs off on it too, which is a good thing. I mean, that's a fantastic safety feature for you all. So if we have a 70 kilo adult, that works out to about 70 units per hour.
So,
Yeah, yes, I'm sorry. Yes, 7.
Or 7 minutes.
7 units. 7 units per hour. And if the glucose doesn't fall within the range of 50 to 70, okay, let's back up. So the goal is to not drop the blood sugar too quickly, but to lower it steadily and safely, ideally by about 50 to 70 milligrams per deciliter per hour. So this is the first time that I've actually ever seen that range provided. Because in the ER, my goal is to get them onto the floor, right? We identify it, and then we're like, okay, go away. We don't want you here anymore. So this was actually new news for me. But according to your text, our goal is to drop it 50 to 70 milligrams per deciliter per hour. And if the blood sugar doesn't fall within that range during the first hour, the blood sugar is then rechecked and the rate is adjusted. So different hospitals will have varying protocols on how you're going to adjust for that. So when you're in practice, you need to make sure that you're following your hospital's policy and their insulin dosing procedure. During this time, blood glucose is monitored very frequently, usually every hour, because insulin needs can change really rapidly. And as the patient stabilizes and the glucose levels approach normal, checks can be spaced out to every 2 to 4 hours. Once the blood glucose reaches about 200 to 250, the patient is then decreased to about half that rate, so it's 0.05 units per kilogram per hour. But before the patient experiences that decrease in insulin, the provider has to make sure that they're rehydrated, that their acidosis is improving, and that their ketosis is improving.
So originally we're checking them every hour.
Yes. And it's a capillary stick.
Okay. And the bolus is going to be
0.1 units per kilo.
kilo, and then the infusion is 0.1
Correct.
units per kilo per hour.
Yes, which is nice that it's the same,
Yeah.
because we have had some protocols that are just all over the place, but at least this one is consistent. Once insulin therapy begins, potassium levels are checked frequently, usually about every 2 hours. So that patient is going to have a blood draw per their IV or central line, whatever they have, to have that potassium checked, because levels can fall really quickly as that acidosis resolves and that potassium is shifting back into the cells. Because of this, potassium chloride is usually added to their IV fluids to prevent that fall to occur quickly. We also must be monitoring those patients' EKGs and telemetry to make sure that we're watching out for any cardiac dysrhythmias. And then as fluids and insulin are administered together, the ketotic cycle is interrupted. So like we said, that glucose is able to move into the cells as the fat breakdown slows. therefore that ketone production is stopping. And this allows that metabolic acidosis to gradually recorrect. In a lot of cases, insulin and fluids alone are enough to resolve the acidosis. In the past, bicarbonate therapy was used. We try to not use that anymore unless the acidosis is really severe with a really low pH. And blood glucose levels usually normalize before ketones are fully cleared out of the body, which is why the insulin infusion must continue even after their blood sugar improves. So the goal is to make sure that ketosis has resolved, that the patient is rehydrated, and their potassium is within normal limits. Once ketosis has resolved, then at that point the provider typically discontinues the IV insulin infusion and they transition to a subcutaneous insulin.
So, could you say again the reason why we want to keep on giving the insulin even after we've dropped the blood glucose?
So that we can have the ketosis resolved. Because the ketones that are already cycling within the blood won't immediately dissipate. We have to continue to treat in order to allow all the ketones.
You're resolving the acidosis?
Yes.
Okay,
Correct.
so without the insulin, is the insulin going to be doing anything with those ketones, or do they just get sent through the urine?
It just gets sent through the urine. The insulin doesn't affect the ketones, but we provide insulin until the ketones have passed, until that ketosis has resolved.
Okay, so it could have already resolved, but we're just making sure that it
Yes.
is actually gone.
Yes, that is correct. So I found an example of a DKA protocol. So some will be detailed like this and some will not be, but we have a few to look at. So the diagnostic criteria that the providers will use is, what does the blood sugar look like? Are there ketones in the urine? What is the blood pH? Does the patient have a history of diabetes, or is this new for them? And then we need to consider their age, because age places them at higher risk. A lot of times kiddos are really high risk for developing DKA. And do they have any kind of history of recent surgery? Do they have any kind of recent illness? And then what is the first thing we need to do? What do we give them first?
Fluids.
Fluids. Yes, IV fluids. IV fluid resuscitation. Throw a liter on them. We're going to at least give them a liter at minimum to start rehydrating them. And then we look at what? We look at what level before we can start insulin? Potassium. We have to look at their potassium level and see, is it normal? Is it low? And if it's low, it has to be replaced. After that, we can start insulin. And what's our insulin dosage?
0.1 units per kilogram.
Yes, that's exactly right. And then after that, they're going to be reassessed every hour to have their insulin dosing adjusted. And there is actually a written chart that helps you adjust that insulin. So it is not the provider that's going to be putting in that insulin dosing every hour. You're not going to call them and be like, hey, we've gone down to 300, what do you want me to change the insulin to? Most facilities actually have a chart that you have to follow, which is why some of these patients typically end up in the ICU, because the nurses are really having to, A, monitor their blood sugar really closely, but they're also having to adjust that insulin dosing. And then this is just the rest of that chart. So monitoring hourly glucose, potassium, ketones, glucose. And if the patient's blood sugar drops too low, we're actually going to give them, well, honestly, it depends on the facility. We can do an AMP of D50, or they can be transitioned to D5W with normal saline, depending on what the facility wants to use. And then this is kind of what that blood sugar infusion rate looks like. So if you look at the bottom, if that patient's blood sugar is staying at 500, you'll adjust their insulin infusion to 20 units per hour, which is approximately 40 milliliters per hour based on the concentration of the insulin bag at that facility. We have a supplement. So one that you all may or may not have seen is this one. And I have this one because it was actually created for me. So at Ray County Hospital, we start with the patient's weight, and then we initiated some laboratory orders for all providers to enter in. And we did an ABG. The pharmacist helped establish this, and in lieu of a basic metabolic panel, really most of us ended up ordering a complete metabolic just because we wanted to have a little bit more information on liver function and kidney function in lieu of just basic electrolytes. We also had them draw magnesium and phosphorus because magnesium replacement can impact potassium replacement. So if a patient doesn't have enough magnesium, no matter how much potassium you give them, they're not going to be replenished. And then we had our ongoing labs, which there they drew the basic metabolic every 6 hours. Our text recommends every 2. And I tend to agree more with the text so that we can keep an eye on it just a little bit more closely. And then of course they did their blood glucose hourly. And this gave the providers a little bit of autonomy to decide what did we want the initial fluid bolus to be, what did we want the maintenance fluids to be, and then here we have that potassium replacement needed, and we needed to get it above 3.3 before we provided the insulin. And if you look down farther, we had our initial insulin bolus and infusion rate. So they not only provided us with what that initial bolus needed to be based on their kilograms, so they gave us a chart to follow instead of us actually having to calculate it out. And then they also gave us the initial rate, units per hour, that that patient needed to receive after receiving that initial insulin bolus. And this was created actually because, and the last page was insulin infusion titration directions. And it really gave the nursing staff good orders to follow to let them know, hey, do we need to increase it? Do we need to decrease it? What if it's below 70? Well, we wanted them to notify the providers to decrease the insulin infusion all the way down to 1 unit per hour, and then provide some glucose at that point, because that's way too low for that patient. But ultimately, this was created because when I was there, I was able to complete my doctoral thesis on the DKA protocol that they established for me, which was super fun. And when I was doing this, my goal was to see not if the DKA protocol was effective for patients. I was looking to see if the DKA protocol was effective for the providers, to make sure that they were following all of current evidence-based practices of what labs to draw, making sure to check the potassium before starting the insulin, and making sure that the fluids were being provided initially. So at the end of my study, we ended up having 13 patients within the month that met criteria for the protocol, and in 62% of those patients, the protocol was followed. So at least it was a positive outcome. At least the providers followed the protocol 62% of the time. So I thought that was a little fun thing to share with you all. Now,
It's very organized.
thank you. I thought it ended up being a very pretty poster.
Yeah.
Like, it was just an attractive thing to have them put on the wall.
Did you even present it?
We did present it, actually. We presented it via a Zoom meeting.
Oh, okay.
Because I completed my work at Stanford in Alabama, and we had, ours, it was one of the only emergency certification nurse practitioner programs in the country. So there's one at Vanderbilt, there's one at Stanford, and there are just a couple others scattered throughout. It's not a common program, which is why I ended up there. That is really interesting. I've lost my presentation, but I see it on your board. Okay. So we saw our supplements. Now, what are some complications that can occur during DKA? So the first thing is fluid volume overload, because DKA treatment requires large volumes of IV fluids to correct the severe dehydration that results from the disease process. And patients with underlying heart failure, kidney disease, they're really vulnerable to developing fluid volume overload because they simply don't tolerate that rapid volume expansion well. When the fluids exceed the kidney's ability to handle them, then of course the excess fluid backs up into the lungs and the circulation. So we see our common symptoms of overload like crackles, neck vein distension, shortness of breath, and we manage this by slowing the IV fluids per the provider's orders. We of course elevate the head of the bed, and we want to make sure that we are also obtaining hourly urine output evaluation to ensure that that patient is having adequate output. We can also have hypoglycemia when we're treating DKA, and this occurs most often as a treatment-related complication of the insulin therapy. So as the insulin lowers blood glucose, the levels can fall too quickly if the insulin dosing or if dextrose supplementation isn't provided and adjusted appropriately. And this risk of hypoglycemia increases once blood glucose improves and those monitoring intervals are extended in some protocols. So we need to be aware of symptoms of hypoglycemia. And the main ones to watch out for are the sweating, the tremors, confusion, worst case scenario, decreased consciousness. And the patients also need to be aware of these symptoms so that they can notify you. Preventing hypoglycemia relies on frequent monitoring of the glucose, and typically that is every hour upon the initiation of therapy. And then when the glucose level approaches 70, at that point we want to make sure that that patient is having dextrose added to the IV fluids to prevent further fall. If hypoglycemia occurs, common recommendations are to actually stop the insulin altogether and provide IV dextrose. And then that blood sugar should be reassessed every 15 minutes until that patient is stable. Potassium disturbances are also really common in DKA because of that insulin resulting in the potassium shift back into the cells. So even when initial potassium levels are normal, that patient typically experiences potassium depletion due to urinary losses from the osmotic diuresis. And as that insulin therapy begins, that potassium can fall really quickly, leading to hypokalemia. Hyponatremia can occur because the sodium is lost through osmotic diuresis and compounded by vomiting and diarrhea, which are some really common findings in diabetic ketoacidosis. And in addition, dilutional effects occur when water shifts from the intracellular to extracellular space, responding to that hyperglycemia the patient is experiencing. And symptoms of hyponatremia include orthostatic hypotension and mental status changes. And the initial treatment is with isotonic saline to help restore that circulating volume. And then there should be some ongoing fluid management. We just have to make sure that we're monitoring those patients really closely, because sometimes we can replace their sodium just a little bit too quickly. So we need to monitor their level of consciousness. Changes in that patient's neurologic status can result from rapid shifts of the sodium. And cerebral edema, while rare in adults, is a really serious complication in kiddos with DKA, and it can develop because of the rehydration and rapid elevation of the sodium levels. So we're going to want to watch these people for development of headache, confusion, or just a sudden altered mental status in general. DKA places these patients at skin breakdown because of the dehydration and hypovolemia. This results in reduced circulation and makes the skin a little bit more fragile. So we need to make sure that we're repositioning them and we're inspecting their bony prominences and working to minimize friction. We also need to make sure that we're providing good oral care, because dehydration leads to dry mouth and decreased saliva production, which increases the potential for bacterial growth. Therefore, regular oral care helps prevent the breakdown of the mucosa and the development of infection. And in general, we need to make sure that we're watching these patients for infection, as hyperglycemia does impair that immune response. So make sure that you all are following good aseptic technique with IVs and blood draws in these patients. So the kind of complement of DKA is hyperglycemic hyperosmotic state. And this is an acute life-threatening metabolic emergency in type 2 diabetics. The development occurs more slowly than diabetic ketoacidosis, and instead of being in 24 hours like in DKA, it usually occurs over several days to weeks, and it's characterized by extreme hyperglycemia and severe dehydration. HHS occurs when there isn't enough insulin to move glucose into the cells, so that blood sugar rises, and while there's high glucagon levels, it causes the liver to release even more glucose. This makes the blood extremely concentrated, and to compensate for this, water then begins to shift out of the cells and into the bloodstream, leading to severe cellular dehydration, especially in people who don't feel thirsty or don't drink enough. And that's really in the elderly population, because they have that decreased thirst drive. Although glucose spills into the urine, the kidneys simply can't eliminate it fast enough, and large amounts of fluid and electrolytes like sodium and potassium are lost, because the body is just simply trying to rid itself of that excess glucose. But unlike DKA, ketones are usually absent. Stress hormones add even more glucose to the bloodstream, worsening this cycle. And without aggressive fluids, the insulin-related reduction of blood flow and oxygen delivery to the brain can cause confusion. So HHS occurs most frequently in older adult patients with type 2 diabetes, and this sustained hyperglycemia results in prolonged osmotic diuresis, leading to profound dehydration and electrolyte disturbances. Like previously mentioned, older adults are especially vulnerable to this due to that decreased thirst perception. And common precipitating factors, very much like DKA, do include infection, stress, myocardial infarction, stroke, and sepsis. There are also certain medications that contribute to the development of HHS, and this includes steroids and beta blockers. HHS usually develops pretty slowly and quietly over several days, so the early signs are really often missed. And at first, people just feel a little generally unwell. They tend to urinate just a little bit more often and feel a little bit thirsty if their thirst response is intact. But as the fluid volume depletes, those patients experience weakness and fatigue, headache, blurred vision, orthostatic hypotension, and tachycardia. But unlike DKA, ketosis does not occur, so there is no fruity odor to their breath, and there are no Kussmaul's respirations. Neurologic manifestations are more pronounced in HHS because of the extreme hyperosmolality. And these patients may develop confusion and lethargy and altered mental status. They can also develop seizures, and coma typically occurs when their serum osmolality exceeds 350. Laboratory evaluation confirms the diagnosis and guides the treatment, and these blood glucoses are usually a lot higher than DKA, so they are typically over 600 milligrams per deciliter.
So they can literally go into a sugar coma.
Yeah, very literally. The ketones are absent in both the blood and the urine, which is the distinguishing feature of HHS from DKA. And serum osmolality is markedly elevated, often greater than 320. Electrolyte abnormalities result from the severe dehydration, and intracellular potassium is usually depleted as a result of the osmotic diuresis. The UN and creatinine levels are also elevated due to the dehydration, but ABGs are typically normal because there's no production of ketones. In HHS, our treatment includes provision of IV fluids, and sometimes this provision of IV fluids can lower the blood sugar and improve symptoms because rehydration dilutes the glucose and improves kidney perfusion. Even if that happens, insulin is still recommended because without it, sometimes acidosis can develop because the cells are not effectively using the glucose. So insulin helps move the glucose into the cells and stop the cycle of rising blood sugar. Blood sugar can be lowered in a couple ways, but the most common approach is to start a weight-based IV bolus of regular insulin, again followed by that continuous insulin infusion, and this, like DKA, is dosed at 0.1 units per kilo per hour. And the goal is to, again, lower that blood sugar by 50 to 70 milligrams per deciliter each hour. If that insulin infusion is not effective at ensuring that reduction at that rate, sometimes the insulin infusion is increased, and sometimes it's even doubled depending on the hospital's protocol. When IV insulin is given, it does cause the potassium to move into cells pretty quickly, so because of this, it's also important that you're reassessing potassium in HHS. And again, if the potassium is below 3.3, it has to be corrected. So when treating patients with HHS, you're going to be giving the fluids and the insulin and the electrolyte replacement. And it really requires careful control of IV fluid administration. You want to, again, make sure that you're monitoring these patients for fluid volume overload. And you're going to be having strict outputs, so you're going to be monitoring all of these patients' output. If the patient is awake and stable, fluids and electrolytes can be given both orally and peripherally because the goal is to rehydrate them. And in cases where you see indication of hypovolemic shock from the dehydration, we can use more advanced monitoring like the arterial lines we talked about in shock. It's really important that hospital protocols are followed, especially when managing hypoglycemia, although you're probably not going to see that too often in HHS. And you're still going to be doing those hourly blood glucose checks to ensure that there is good response to therapy. You're going to want to make sure that you're monitoring the blood pressure and the heart rate closely to assess the patient's dehydration and see how well that fluid replacement is working. Because these patients are older, a lot of them have a lot of underlying heart and kidney problems. So you really, again, want to make sure that you're monitoring for that hypervolemic status. You're going to listen for the crackles in the lungs, look for that distended neck vein. And then you're also going to want to make sure that you're just assessing them regularly per protocol. So we're going to listen to our little purple nurse. I don't know her name.
That's what Nurse Sarah.
Yeah, purple nurse. For just a few minutes.
She's wearing purple.
If we can get my, but she's not wearing purple today.
They might think.
She is wearing pink.
She's a tree.
Let me make sure that my speaker's on.
I know. Hers is
What?
like 30 minutes long.
That's a short video.
Oh, is it? I don't like showing long videos in class. I don't think it's, I don't know. I just don't think it's good practice. Oh,
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over DKA versus HHNS. These are two complications of diabetes mellitus, and what I want to do for you is simplify those subtle signs and symptoms and those differences so you can get them right on your exam. Now this video is part of an endocrine series, and in the previous video I covered in depth DKA, where I covered the patho, the nursing interventions, the pharmacological aspects, and in the other video I covered HHNS in the same way. So if you want to access those videos, you can access the card above and it'll take you to a playlist and you can get to those videos. Now after this video, be sure to go to my website, RegisteredNurseRN.com, and take the free quiz that's going to quiz you on the differences between DKA and HHNS. So let's get started. Behind me I have this table, and in the table I have put the differences between the two so you can easily see it. So what we're going to do is we're going to go through DKA and then we'll go through HHNS and compare the two. Okay, diabetic ketoacidosis and HHNS. HHNS stands for hyperglycemic hyperosmolar non-ketotic syndrome. Let the names help you because they explain a lot of the differences between these two issues. Okay, DKA, diabetic ketoacidosis. This is mainly seen in your type 1 diabetics. It can be seen in type 2, but it's type 1, so remember that. HHNS is mainly seen in type 2 diabetics. Ketones and acidosis is present in this. This is because you have the breakdowns of fat because this patient has absolutely no insulin in the body, so the body needs fuel, so it breaks down those fats, hence ketoacidosis. However, HHNS, there is absolutely no breakdown of ketones or acidosis. So you're not going to see any ketones in the urine, and the patient's not going to have metabolic acidosis because there is just enough insulin in the body to prevent the body from breaking it down and breaking down fats. And usually these cells are just not receptive to insulin, but there is some insulin. That's why most of your type 2 diabetics, this is seen in. In DKA, you have hyperglycemia. You're going to have hyperglycemia in both of them, but with DKA, it's just going to be greater than 300 milligrams per deciliter. It's going to be elevated. But with HHNS, you are going to have heavy-duty hyperglycemia. Remember the little mnemonic, the two H's in HHNS? HH, heavy-duty hyperglycemia. These sugars are going to run greater than 600. You can see them not even registering on a monitor. You may have to get an IV draw, or they will be 4-digit. These glucoses are super high in these patients. In DKA, the osmolarity is variable. It's not much of an issue as it is in HHNS. You're going to have really high osmolarity. And this is due to because the blood is super concentrated with those crazy glucose levels. So you're going to see a lot more problems due to the osmolarity in this condition, like dehydration, than you will see in DKA. DKA happens suddenly, fast. It comes on. HHNS, it's going to happen gradually over time. DKA, the causes, you have no insulin present, so that's one cause. Maybe they haven't been taking their insulin injections at all. Illness, infection, they needed more insulin because they're not taking as much because their body's stressed out, but they needed more, but they didn't know that. They've been skipping meals, again, because they don't feel good, or they don't know that they're diabetic. This is usually one of the first signs in newly diagnosed diabetics is DKA. Causes of this, the cells again are just not receptive to insulin. There's just not enough present, but there's just enough present to prevent ketosis. The main cause of HHNS is usually because that diabetic patient has a severe infection or illness. This is mainly seen in your young and newly diagnosed patients compared to HHNS. This is going to be seen in mainly your older adults who are presenting with a severe infection. Main problems include hyperglycemia, you're going to see that, ketosis, and acidosis, where the blood pH will be 7.5 or less, and bicarb will be less than 15. However, in HHNS, you are just going to have that extreme hyperglycemia and dehydration, severe dehydration, due to that hyperosmolarity, that concentrated glucose in the blood. Treatments are the same for these, which will include IV fluids, insulin, electrolyte replacement, more likely the potassium replacement. However, with HHNS, one of the best treatments is just getting them rehydrated, because those cells are literally shriveled up, not gone, but they're wasted, and rehydrating them is actually going to move your electrolytes back. It's going to decrease that blood sugar just as well as the insulin. So IV fluids is super important in our patients with HHNS. DKA, one of the typical signs, because both of these conditions, you're going to have polyuria, you're going to have polydipsia. But the big differences in signs and symptoms is that these patients in DKA can have the cosmal breathing, and this is due to the metabolic acidosis, where the body is trying to blow off that extra acid, the carbon dioxide, to try to compensate for these acidotic conditions. So it's rapid, deep breathing. And they will have the acetone breath and abdominal pain, and this is due to the ketones breaking down. However, remember, in HHNS, you don't have the ketosis or acidosis, so you won't have cosmal breathing or the fruity breath, but you're more likely to see mental status changes in these patients due to that severe dehydration that they're experiencing. So that is the difference between DKA.
And she did a really great job at compressing that information to give you the comparison. I think the comparisons are incredibly helpful for you all as you learn the difference between all of the endocrine disorders. And like I said last time, really the ones that you're going to see the most are really just DKA. I mean, you may see HHS, but DKA is one that you will very likely see on the influx. It's a very testable one.
I took care of it, we took care of a patient with DKA the other day, but I think, or it was a couple of weeks ago, but he had really high blood sugar.
Did he?
Yeah, but she said it wasn't normally that high.
It's usually not terribly high, but sometimes it can be. And then I just provided a comparison as well, so that you all had that in your PowerPoint. That should be at the end of your PowerPoint presentation, yes? Okay, that's perfect. Now, I also tried to do what is that thing that you all like so much?
Mm-hmm.
Yes. Which is,
I wonder if any other school does this.
I don't know, but I tried to make 2 different ones, and I don't know how.
Are you going to do together?
Yeah, let's just go.
Oh, okay, there's your pen. Awesome.
Dr. Could you also upload the other comparison tables?
I would be happy to,
Okay,
yeah.
thank you.
I can upload both of those. It seems like I tend to add things the more I think about our lectures. So things just appear in them.
No.
Doesn't that look like what?
America.
And unfortunately, I think that's just kind of
You should click
the
it.
effect of creating a class because
Yeah.
it doesn't exist. So as I think about it, I'm like, oh, I need to add this. Yeah.
Remove participants. Why do you look so sad?
It's because she's about to be removed.
Is everyone in? Everyone who wants to be in? Yeah? Okay. And I tried to make these questions pretty easy, and hopefully it doesn't repeat itself. So this is the first set of endocrine, okay? I did 2 different ones.
I literally said true, Kayla.
I got some.
I'm just kidding. I'm just messing up. No, we can mess up, it's okay. Still getting that class.
Oh, yeah.
Good job, guys. Yay!
You said no problem.
And I didn't pick these pictures, so don't pay attention to the pictures because that's not me. Yes. Yay!
AJ, get down from there, bro.
Zero asshole.
I'm
Wash bench.
Yeah, I don't want to wear shoes. I was gonna press that. Who got it? She's like, what did you press? Because I was like, why did I
What are the rest of those symptoms?
Hypo.
Hypo. That's right. The rest of those are associated with hypo. Oh.
Ooh.
And like the rest of those are associated with hyper.
I accidentally diagnosed and then he went over. And I was right. I was like, I'm so sorry. I
Oh.
was like, typically I'm a nursing student, so please get your lunch. Yes. It literally said the picture.
Oh, did it?
Yeah, there's a picture and it had fluid on it. It was on me.
I feel like diabetes insipidus kind of tries to confuse you all because it has the word diabetes.
Who has some pink urine? It's like very pink.
Why are they holding it without a glove stand?
I know. You make that mistake once in your life.
Oh no, I can't tell you how many ER nurses I see just carried around urine.
I
Here,
say
just
no.
give me urine.
I'm like,
Have
with
you
my
seen
gloves
that?
on, you can.
Have any of y'all seen that? No? Yes, okay. I don't like to touch people's bodily fluids,
Yeah.
so I will always glove.
And then you touch your face.
Mm-hmm.
Wait, what's this question?
Oh, it's on.
What is symptoms of thyroid crisis, thyroid storm?
Oh, it's multiple.
Mhm.
Oh, he said,
Because I was like,
you said.
I was like, it's that one or that one? It can be both.
It was a trick question.
It wasn't
Which is one?
Greg.
Trick game of question. I don't remember what I think it was. Cocaine. It is definitely salt.
They like their coca.
Coma. That's good.
Oh. What? Wait. Oh, I thought it was a select on little flag. Oh no. Oops. Got hit 5 for one. I thought it was select on little flag.
Just another psychology.
No, it's a
Oh,
one or the other.
He's gonna. Wait, I gotta take a picture of that after it.
Again, I didn't choose this picture.
Did you see how cool? He's gonna die.
Don't quote me on it.
Okay, good job.
I guess that was.
So it is rare for people with hypothyroid? Because if they went undershirt, it's still. I know, one more.
Yay! Good job, guys. All right, we have one more. If I can figure out how to do it.
Oh, that's really good.
Okay.
I get it.
Oh, there it is.
Yeah, we got some. We're doing another one?
Yeah, there's one more.
Oh,
Yes,
I
yes.
love counts.
Oh, it's okay. This one is about our DKA, HHS, and the adrenals. So I made one for both of the lectures. And I'm taking way too much credit. Like, I uploaded my PowerPoints and had Kahoots generated. But I'm just trying to get you all to start thinking about it before you all go into the holiday, because this stuff will be on your next exam. Yeah. Which
I
is,
should put Kayla or Kayla to dog because.
are you all in? All in, who wants to be in? Yes? Okay.
daily exercise.
Adequate sleep, don't sleep, guys.
Nope, sleep's bad.
Oh, wait. I didn't know what I was looking at. I was like,
True is always on the left.
until I switch it. And I'm like, Right, probably not. Look at that man.
Get the antibiotics fast.
Mm-hmm. Yep.
Mr. Homework. I've seen somebody that had over 1,000.
Really?
Yeah, and I was like, how is she not dead? And that was before I was in nursing school. I was like, I'm so sorry. Oh, they did it.
Yeah, I do. Sorry. Oh, dude.
I was like, I
But
didn't think
it's
about
the
it.
Merlin's, not that.
Yeah, it kind of gives you the answer.
Yeah, it was a movie face. See, they got the tricks on. Yeah. I know.
Which one are you saying?
Yes.
These
I didn't
pictures
even
really
look
need to be removed.
Yeah, I agree.
Until
I
before
agree
I
with
looked at
that.
the picture and they're like, wait, the picture said it's like somewhere.
Oh.
No, this.
It's gonna happen. Did you? Oh, it actually doesn't. Did you? Where did you?
I put it
Okay.
in the library.
You went up.
No, I can't. Oh.
Jokes on us. It's behind the screen.
Right. She's like staring for real.
She's intense.
Some put bumbling.
Me, I did.
Look at his face.
That's a weird picture.
Again, I didn't make the pictures. And I really don't know how to take them off either. So, there they are.
Non-human.
Yes.
You guys see that I can only imagine?
What's that?
The guy,
Imaginary Friends?
no, it's based off of a Christian artist.
Is it already out?
Yeah, it came out, but the son has diabetes.
I don't tell them.
Oh, sorry. Hold on.
Because I know maybe the real one.
Only pregnant people have it.
Yep. Okay.
Let's do school. I didn't think it was gonna be. Oh, shoot. I picked the wrong one. So I did this. Oh, wait, no, I didn't. Okay. I feel like all are.
No, it's because it's not
Oh.
people.
Oh, it's just thinking
I like the hand signals too.
We're working together at home. I have a Grey's Anatomy book. It's not a Grey's Anatomy show. This is already.
We are.
Oh, it's too. Oh, it's literally right
It is
there.
there.
Stop.
Ugh, that stinks.
This is the AI. Freaking bitch. Let me just.
You fight.
Alright guys, that was super fun. So, a follow-up question from the hyperkalemia question. What is our cardioprotective?
Or what?
What do we provide, what do we administer as a cardioprotective
For Friday?
for hyperkalemia?
Is it calcium?
It's calcium.
Oh.
No.
Calcium gluconate?
Calcium, yes. Just calcium, yes. Alright, have a good spring break. Go home. Run, have fun. Y'all are in college, right? So it's fun and oh, thank you. Thank you for letting me. Of course. Is this yours? Whose pencil?
Oh, that was my pen. I found it. If you like a blind chicken.
No.
Just trying to.
Oh, right.
Are you one of the?
Alrighty.
When do you leave for your trip?
Friday morning. Yeah, and we're all a little disappointed that we're too afraid to go to DC. Like I'm really honestly too afraid to go to DC right now.
I wouldn't.
Yeah, I can't do it. Not with Theodore, and I would feel horrible if we went and then something terrible happened.
It's probably for the best.
Yeah, I think so.
Yeah.
I just, and maybe I'm overreacting, but
Well, you know what? It was funny. So we mentioned.